I'm Dr. Ronald Berkman. Today we'll be discussing trial of labor after cesarean, better known as TOLAC. Upon reading the assigned chapter and practice bulletin, viewing this video, and participating in the follow-up session, you should be able to discuss VBAC and cesarean delivery trends, issues in interpreting VBAC data, TOLAC and VBAC results, as well as factors which may increase the safety and success of VBAC. Certainly the rise and fall of VBAC is of some interest historically. In the 1970s, the dictum was, once a cesarean, always a cesarean. However, this dictum was reconsidered when in fact there were a number of case reports indicating that women who had had a prior single cesarean delivery, particularly if it was low transverse, that they actually did quite well if they went on to labor with a subsequent pregnancy. With that information, the VBAC rate nationally went from about less than 5% to as high as 28.3% by 1996, and the cesarean delivery rate fell to about 20% in 1996. In the mid-1990s, however, safety issues again resurfaced with a number of reports suggesting that there were increased complications, both maternal and neonatal, particularly related to uterine rupture when VBAC was attempted. In addition, there were some professional liability concerns that surfaced at the same time. With all of this, in the mid-1990s, the VBAC rate began to fall, such that by 2006 it had reached a rate of only 8.5%. Further, the cesarean delivery gradually increased to a rate of 31.1% by 2006. If we look at this graphically here, you can see the red line showing the rise in VBAC from 1990 to the mid-90s, and then a precipitous fall related in 1996 to some adverse reports, as well as 1999 when ACOG had in its requirements that one had to have an OR immediately available as well as someone able to do a cesarean delivery. Further, you can see at the same time the cesarean delivery rates increased. So here's information from the practice bulletin in 1999, where basically on the left hand they basically said there was no traditional contraindications of vaginal delivery. If one had 1 or 2 prior low transverse scars, things were okay, and obviously no prior uterine rupture. But one also had to have a clinically adequate pelvis. But the major reason that the VBAC again became of concern was also the requirement of the immediate availability of a team to perform an emergency cesarean delivery. And this again was an issue particularly for smaller hospitals. In fact, if you look at the whole state of California from 1996 to 2000, you can see that they had a VBAC rate in 1996, which was approaching 25%, but by 2000 it had dropped to 15%. Again, all because of some of this data. So what are some of the factors that also have contributed to the rise in the cesarean section rate? Certainly there are demographic shifts. Certainly there are more nulliparous births than there are parous births, and a substantial number of women are delaying childbearing such that when they decide to bear children, many times they will accrue a variety of illnesses or issues that would affect their ability to successfully complete a pregnancy without their obstetrician resorting to a cesarean delivery. Further, there have been a lot of practice changes. There's been increased use of electronic fetal monitoring, and again, if used occasionally inappropriately, this also can lead to an increase in the cesarean delivery rate, as has been demonstrated over the years. Vaginal breech deliveries have virtually been abandoned in this country, and this has resulted obviously in more cesarean deliveries for this indication. And also there has been declining use of operative vaginal delivery to a rate of only 3% in 2013. The use of assisted reproduction has led also to an increase in multiple gestations. In the state of Massachusetts, for example, ART accounts for about 4% of the multiples in the state. And related to all of this have been medical legal concerns as to should we in fact do something that might put us at risk, and therefore there's a reliance on proceeding to cesarean deliveries much quicker than perhaps in the past, such that routine repeat cesarean delivery rate in 2001 was in fact at a rate of 39%. Now, there are a lot of issues in interpreting TOLAC data. First and foremost is that there's very few high-quality studies. For example, Geis, in his review in 2010, looked at 963 articles and only included about 200 of them, and even those were rated only fair to good in his review, and he did point out that there were no high-quality randomized clinical trials. It was also noted that there's no standardized reporting measures for many of the outcomes, particularly uterine rupture, with frequent misclassification. I'll show an example in just a minute. There's a lack of consistency in study populations. For example, are all subjects appropriate candidates for TOLAC in many of these studies? And there's been inappropriate comparisons, such as successful VBAC versus elective cesarean delivery, when in fact the real comparison should be TOLAC versus elective cesarean delivery, since some TOLACs end up as VBACs and some end up as cesarean deliveries. Certainly interventions such as oxytocin use or prognostic factors such as Bishop scores are not always specified in some of the studies. Here's an example of a MMWR published in 2000 looking at the accuracy of hospital discharge data for uterine rupture over basically 7 years in Massachusetts. Uterine rupture was defined as any unintentional disruption of the uterine wall. There were about over 1,200 cases suspected of having uterine rupture using ICD-9 codes, but unfortunately only 58% were confirmed as non-ruptures on chart review, meaning that in fact there's a substantial number that were listed as ruptures that in fact were ruptures. Overall, the positive predictive value of ICD-9 codes for uterine rupture was only 39.8%. So what's some of the morbidity associated with attempted vaginal delivery through TOLAC as opposed to an elective repeat cesarean delivery? And if we look here at this chart from the recent ACOG practice bulletin comparing the maternal risk, overall the rates are reasonable using both approaches. Obviously, as one might expect, you have more infectious morbidity with TOLAC because some of the TOLACs end up with a cesarean delivery when they fail. Similarly, you may have more surgical injury, more blood transfusion, and the like. But when you look at the overall rates and risk and so forth, they certainly are quite reasonable, particularly the one that has garnered the most attention, and that's uterine rupture, and uterine rupture being less than 1%. The composite neonatal morbidity also is in reasonable ranges, though obviously there are some differences when you examine TOLAC versus elective repeat cesarean delivery. But even the increase you see in that particular column certainly is reasonable and should not discourage one with the right indications to proceed with a TOLAC. And certainly there's advantages with a successful TOLAC, which obviously is a VBAC. One avoids major abdominal surgery. Overall, there's a shorter recovery time compared to elective repeat cesarean delivery. If one is planning a large family, you avoid the complications associated with multiple repeat cesarean deliveries, but you need to keep in mind that 20 to 40% of TOLACs are unsuccessful. Most of the morbidity is in this group when repeat cesarean delivery becomes necessary, usually after a long or prolonged labor or some complications of a labor requiring that a repeat cesarean be performed. Prognostic factors for successful VBAC has been examined in a number of studies. Here's one where a number of studies were pulled together, and the author Hashishima here did point out there was a paucity of high quality data to govern decision making. But certainly in this particular paper, the favorable prognostic factors included prior vaginal delivery, a favorable Bishop score, spontaneous onset of labor, breech as the indication for the prior cesarean delivery, and maternal age less than 40. Unfavorable factors were previous dysfunctional labor, the need for induction or augmentation with the TOLAC, non-reassuring fetal heart rate tracings on admission, and also of interest, in a history of substance abuse. Others have looked at this, and this was summarized in the recent ACOG practice bulletin. Certainly with prior vaginal birth and the onset of spontaneous labor with this subsequent pregnancy, these are strong predictors of success, and a decreased probability of success includes many of the ones already listed by the Hashima paper, but including, again, recurrent indication for initial cesarean delivery, particularly some dystocia with the labor, increasing maternal age, non-white ethnicity, being post-dates, maternal obesity, being preeclamptic at the time of labor during a TOLAC, a short interpregnancy interval, and increased neonatal birth rate or macrosomia going into labor. So which uterine scars are okay for TOLAC? This is an area obviously of importance because one would like to avoid the risk of uterine rupture by perhaps not trying to carry out these procedures in the wrong individuals. One question that is raised, is it riskier to perform a TOLAC with 2 prior cesarean deliveries as opposed to only 1? And it can see with 2 studies with a reasonable number of subjects essentially showed that in one study there was some increase in the risk of uterine rupture. That is the Maconis study of 2005, basically doubled the rate to about 1.8%. However, this is certainly still reasonable. In the Landon study, there essentially was no major change. Both of these papers did show some increase in major morbidity when 2 prior cesarean deliveries had occurred, but the magnitude of the increase was small. And their bottom line was that in the absence of other mitigating factors, 2 prior cesarean deliveries is not a contraindication to a TOLAC delivery. And here summarizes a whole list of incisions and uterine rupture risk from the Williams chapter in the 25th edition. And you can see in the yellow having a low vertical, a low transverse, whether it be one or multiple, and a prior preterm cesarean delivery. And here I insert a little bit of caution, this meaning not a very preterm cesarean delivery. All of these are reasonable reasons that one can proceed with a TOLAC. Having a classical prior incision or T-shape, or a low segment and upper segment uterine rupture, these are all contraindications for attempting a TOLAC. Myomectomy is sort of a borderline, and again, if one required a large incision to remove it, then certainly one would, as noted here, the patient would not be a candidate for a TOLAC. But if it was a small myoma, particularly if it was more into the lower uterine segment, such a patient might in fact potentially be a candidate for a TOLAC. Other conditions where TOLAC may be considered, an infant who appears to be macrosomic. Certainly VBAC success is less, especially if the prior delivery ended up with a cesarean due to dystocia or failure to progress. There's possibly an increased risk of uterine rupture if there has been no prior vaginal delivery in such cases. Having a gestational age over 40 weeks, VBAC success has consistently been shown to be less in multiple studies. Some of this may be related to an increased risk of changes in the fetal heart rate, which have the obstetrician proceed more likely towards a cesarean delivery. However, clearly there's no increase in the risk of uterine rupture. Twins, Tolac appears to be similar in terms of outcome when twins are allowed to labor compared to singletons, and there appears to be no increase in risk in uterine rupture when Tolac is carried out with twins. Obesity, with increasing BMI, it's inversely associated with successful Tolac. But you need to keep in mind, despite decreased success as women's BMI becomes higher, the morbidity associated with a cesarean delivery also increases as one becomes in the higher ranges of, say, a class 3 obesity classification. Unknown prior uterine incision. In general, most of these individuals are Tolac candidates, particularly if there's been only one prior incision. Particular caution, as already noted, should be carried out if in fact the delivery was done for a very premature fetus where a classical incision was more likely. What about induction of labor with Tolac and the risk of uterine rupture? And here are two large studies that have examined this. And if you look at both of them, you can see that with spontaneous labor, the risk of uterine rupture is substantially lower in these studies than, say, induction of labor, particularly induction of labor with the use of prostaglandin. And even without the use of prostaglandin, there is some increase. Certainly when the data is confined to women with just one prior cesarean delivery, the increase in uterine rupture appears to be only among those without a prior vaginal delivery. And as noted, again, the use of prostaglandin is not indicated because of some of the increase in uterine rupture as shown here in this study and other studies, so that prostaglandin for cervical ripening are used in conjunction to actually induce or augment a labor should be avoided. Risk of uterine rupture with induction may also be related to oxytocin dose, whether it's the overall duration of use as sort of a dose response or the use of higher concentrations. As we already mentioned, induced labor is less likely to achieve VBAC than spontaneous, and the results do appear to be variable regarding whether augmentation increases the risk of uterine rupture. Getting back again to the information regarding cervical ripening and the use of prostaglandin, there are several studies that did show increased risk of uterine rupture with the use of misoprostol. There's limited data on the use of Cervidil, however. Studies that have evaluated the risk of prostaglandins as a class in studies of Tolac also have a lot of inconsistent results. Overall, prostaglandins are avoided when in fact one is dealing with a Tolac in a term size infant. However, prostaglandins certainly can be considered for use if one has a second trimester delivery due to, say, a fetal death and so forth, particularly if it's a relatively early second trimester delivery or induction that's being attempted. And what is the vaginal delivery rate with Tolac? This is another one of the large studies done by Geis. And the quality of the evidence was fairly good. The data was fairly consistent across all studies. The overall rate of a successful Tolac, looking at all types of facilities, was about 60%. However, when in fact Tolac was carried out in a tertiary center, this climbed to as high as almost 76%. As already mentioned, when the Tolac occurs and it follows a spontaneous labor, approximately 80% of the time one can have a successful vaginal delivery. However, when oxytocin is utilized, that rate drops, and when in fact oxytocin is used as an induction because there's no spontaneous labor, it can drop to as low as 60%.